So welcome and good evening. My name is Donna Amaral, and I am an elected member of the Board of Health and a psychiatric mental health clinical nurse specialist. May, as you know, is Mental Health Awareness Month, and the Board of Health has sponsored events that educate our community about this important public health issue. We can move forward together for mental health by increasing our understanding of some of the challenges experienced by youth, families, and ourselves. Remember, early intervention is key in preventing a mental health crisis or tragedy. Tonight's presentation, Promoting Parents' Infant Emotional Well-Being, Perinatal and Postpartum Support, was developed in response to the tragedy that happened in Duxbury this past January, and subsequent questions and comments in the community that demonstrated misunderstanding of postpartum depression. It is an opportunity for open discussion and to improve our understanding of how what is now referred to as perinatal and postpartum mood and anxiety disorders impacts both parents, infants, and children. There will be an opportunity at the end of the presentation to ask any questions and to provide additional comments or additional information. And so this evening, Carrie McCarthy was to present. However, she had a family emergency, we found out yesterday, and she was unable to be here tonight. She oversees the Cape and Islands Perinatal Wellness Alliance, formerly called the Maternal Depression Task Force. This agency's mission is to create a landscape of equitable and accessible support for mothers and to enhance healthy outcomes related to mental health and well-being during the postpartum period through education, clinical and emotional support, and community. In her absence, I will be sharing her information with all of you. I have over 40 years of experience as a mental health professional, and I currently work at McLean Hospital. I also have 3 years of experience as a high-risk labor and delivery nurse. I have worked with women experiencing postpartum depression in clinical practice, both in outpatient and inpatient settings, and I have recently learned more about perinatal mood disorders in my personal life. For the past almost 3 years, I have been a support to a young family through 2 postpartum depressions, where the mom, and I will call her Jay, required inpatient and outpatient treatment for her depression, anxiety, and OCD. I will refer to my experience with Jay and her family during this presentation. So here first we have the inaugural Maternal Mental Health State Report Card. And this was done by the Policy Center for Maternal Mental Health in collaboration with George Washington University. It is the first comprehensive report and grading of state efforts to address maternal mental health. They evaluate 3 areas. 1, providers and programs. 2, screening and screening reimbursement. And 3, insurance coverage. Where did Massachusetts fall in that? Massachusetts received a C minus, which is actually better than the national average. The national average in grade was a D. And 42 states received a grade of D or F. California has the best grade so far. So this just tells us that we have a lot of things to work on. And if you want to know more about what's happened in Massachusetts and other states, you can go to 2020mom.org, and it has very detailed information about what areas did not do well in each state. Okay. In Massachusetts, we know that Massachusetts received a D for providers and programs, a D in screening and screening reimbursement, but a C in insurance coverage. And Dr. Yagman is going to talk a little bit about some of that. So postpartum depression versus perinatal mood and anxiety disorders. Why the shift in language? The reason for that is historically, the diagnosis or description of a shift in mood in postpartum was focused on depression and depression only. What we recognize now is that there are more symptoms, and that these symptoms and changes in mood can occur early during pregnancy and then continue up until about a year after delivery. So facts about perinatal mood and anxiety disorders, PMAD. Perinatal mood and anxiety disorders are the #1 complication of pregnancy and the postpartum period. And about 800,000 plus people are affected each year. 1 in 5 women and 1 in 10 men experience depression or anxiety during the perinatal period. Dr. Yagman's going to talk more about that as well. And only 25% of those impacted by PMAD are identified and receive treatment, which means all of us that are in the healthcare community need to do a better job of assessment, of asking the questions. And if you want more information, and all this information is available at Postpartum Support International. It's a great resource in the community, and all this data is there. So perinatal mood and anxiety disorders, these are the diagnoses so far: depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, bipolar disorder. And what's interesting about this is that many times when a woman is pregnant, this is when she's diagnosed, that she'd gone undiagnosed for a long time. And then postpartum psychosis, and I'm going to talk more in detail about that. So know that, again, the Postpartum Support International is the best resource to get more data on all of this. Each of these diagnoses or disorders will have a variety of symptoms, and I will tell you that symptoms will overlap. So you can't have anything clear one or the other. And really, in this category, it's health care professionals like a psychiatrist, an MD, a nurse practitioner who would diagnose that. That would not be something that we would do. But we can identify the symptoms and then report that to get help. So we're going to talk a little bit more about that as well. So what does it look like? What it looks like is a lot of major depressive symptoms, and feeling sad and hopeless and overwhelmed, feeling worrying and anxious. My friend Jay had many of these symptoms, but the symptoms that were of most concern to me were the last 3 on here: trouble bonding or lack of interest in baby, persistently doubting their ability to care for the baby, and thoughts of harming oneself or the baby. Okay. And I'll talk more about the thoughts, but that is what would differentiate a perinatal mood disorder from just a major depression. So 20% of women will experience a significant symptoms of depression or anxiety, 20%, during the postpartum period, and the perinatal period. So let me talk about intrusive thoughts versus postpartum psychosis. This is a much more detailed area, so I'm going to talk a lot about this and not be on this slide for a while, because I will tell you, I have worked in mental health care for over 40 years, and I learned about the differentiation of these two things by helping my friend. So let's talk about intrusive thoughts. They're also known as obsessions. the obsessive thinking the same thing over and over again. The thought keeps intruding into the person's psyche. They have a lot of anxiety, shame, and guilt related to the intrusive thoughts, especially if it's about harming the baby. And they're horrified by these thoughts. And my friend Jay said, I would never do anything to hurt my baby. But there were thoughts there. So they're persistent, repetitive, scary, and frightening. Mental images may occur. These thoughts are upsetting and something that the woman never experienced before. So baseline, this is not a way that her thought process went. And there is no supporting research to show that intrusive thoughts lead to catastrophic outcomes such as infanticide. So I want that to be clear when we get into the psychosis part. You'll see why. So compulsions are when the mother's behavior starts doing certain behaviors to decrease her anxiety. So it might be organizing, it might be checking and counting. My friend Jay, she kept focusing on clothes. If her little girl was going to have clothes, she had a 2-year-old at the time. And she was growing and what was going to happen, and she kept obsessing about this. And I found myself, to help her, going out and buying her daughter clothes so she wouldn't worry about it. Because she wasn't able to, because her depressive symptoms were that severe. So symptoms of intrusive thoughts: a sense of horror about the obsessions, fear of being left alone with the infant again, and hypervigilance in protecting the infant. And again, when there are intrusive thoughts, the mothers are often horrified, ashamed, and feel guilt. So do you think they're going to be very open about it? This is where asking those questions about how they're thinking and what they're feeling become very critical, because they're ashamed about the way they feel. They may not readily share that. So when assessing for intrusive thoughts versus psychosis, you're really looking for that perception of the mother saying, this isn't right, I shouldn't, I don't want to feel this way, this is horrible for me. But when there's an absence of that perspective or insight, or simply the mother believes the thoughts that she's having, then you may be looking at psychosis, and that would be considered a medical emergency. So let me just say, postpartum psychosis occurs after childbirth in approximately 1 to 2 of 1,000 births, which you see here on the screen. Occasionally, psychosis can begin during pregnancy or after a miscarriage. So it becomes important to assess after someone has that kind of loss. Of that number, 4% involve the catastrophic outcome of infanticide. So it's a small percentage, but of course we would like to see that be none. Symptoms of psychosis most often begin within the first 2 weeks after birth. So that might be hearing voices, it might be seeing things that other people can't see, it might be severe paranoia where they're afraid of the people in their lives, they're suspicious that they're doing something or they're going to hurt them in some way. And there can be some delirium as well. I think Dr. Yagman addresses that, but delirium is a metabolic state that can be addressed and treated so that there isn't a delirium, but they can be very confused. They may believe things that are not true. Now, if you've ever been with anybody who's had a psychotic episode, you cannot talk them out of what they believe, right? It's they believe this, and there's no talking out of it. So that's not something that you want to spend time and energy doing. It would be to support them in the fact that that must be very upsetting to them, and they must feel so alone in it. At times, the person can lose complete touch with reality. However, it is important to note that those symptoms can wax and wane. So they could have periods of lucidity where they're fine and then slip back into the delusional thinking. So again, reinforcing, it can be a medical emergency. In my case with Jay, she was having those thoughts. She was extremely depressed and not able to function well. She could barely get out of bed. And at that time, she was not agreeing to treatment in hospital. So we worked hard to have treatment at home and to help her and then get her more functional. But there was still concern. And in those cases, when psychosis is present, you don't want to leave the person alone. And that's was key in helping Jay and helping her family. So again, the distinction between intrusive thoughts and postpartum psychosis is the absence of horror or insight into how the woman feels about her thoughts. And Jay was very horrified by her thoughts. So even though the symptoms of psychosis are severe and present a great risk, it's treatable. It is treatable, but it's going to be treatable most likely with medication intervention. And the mother is capable of full recovery. Perinatal psychosis is often unrecognized, ignored, and inadequately treated. If someone is showing any signs or symptoms, as I said before, in psychosis, do not leave them alone, because their behavior is more unpredictable. You don't know if they're responding to voices. You don't know how intense what their experience is internally, so you want to stay with them. And if possible, get them into treatment. As I said, my friend Jay would not go in, but what we did was she was never alone. She was never alone, and we got her treatment at home. So, risk factors for perinatal mood and anxiety disorders, PMAD. Anyone who has a history of depression is at higher risk, okay, or anxiety or obsessive compulsive disorder. And in fact, many times when women have those diagnoses and they're in treatment with meds, their physicians may take them off the meds, which makes them even higher risk. And I experienced that in inpatient practice, where I had a patient who had schizophrenia, who they took her off her meds, and she became more psychotic and had greater difficulty. So she was almost one-to-one on the unit. She was inpatient. Any kind of metabolic imbalances can contribute and be a risk factor, like diabetes or any endocrine disorders, thyroid disease. And lack of supports is a risk factor. If you have a new mom and she doesn't have supports, that's concerning, because we know the demands on moms with newborns. And so just thinking about all of these, I think one of the biggest ones for me is the lack of sleep, which is, I think, on the next slide. As a new parent, you know that when the baby's up during the night, you can't sleep, and regulating that is really important. So if you have pre-existing depression or anxiety and you're not sleeping, it is a higher risk. Mental health challenges during pregnancy happen for everyone, but everyone's different in terms of how they respond. And so knowing the baseline of each person is important, right? What were they like before they were pregnant, before they delivered, to see if there are any changes. And then that will indicate how much you might need to intervene sooner before it gets to a point where it's at a crisis. Hormonal changes, we know, happen during pregnancy and after. And so those changes impact the brain and destabilize and cause mood swings. And so this may happen, it was referred to as postpartum blues, but to the extremes when you're dealing with these disorders like depression and anxiety disorders and OCD, that's at a higher level of distress. Under the best circumstances, adjusting to parenthood is hard work. Adding other factors compounds the feeling of being overwhelmed and stressed. So let's talk about protective factors. You all know that, especially in the mental health field, people can certainly have feelings or intense emotions or depression or anxiety, but they have protective factors, things that stop them from doing something to hurt themselves or others, things that help them stay connected, right? Those are the protective factors. So how is their attitude before, at baseline, before pregnancy, before delivery? Do they have really good supports in place? My friend Jay has an incredible support system in her faith community. And so that faith community provided a lot of support for her, as well as family and friends. And so now I'm part of the family, but I began as a friend. And how they coped before. So if somebody had trouble coping before the pregnancy, before the delivery, if they're having depressive symptoms, then they're going to be more vulnerable to having problems coping after the delivery or during perinatal period. And of course, having a positive attitude. And also in this, protective factors are acceptance, practical, positive attitude, but acceptance of help, accepting the help that we might encourage them to get. When people resist that, it makes it very difficult, which makes it difficult to treat and to take further to get the professional help that they may need, and that the family may need. So, treatment options, there are many. In my professional opinion, medication alone is not enough, and many people rely on the medicines. The combination of medicine and therapy is what will make the difference, because there are going to be things a mom has to cope with and deal with in herself. My friend Jay deals with not feeling like, although she's better now, not feeling like she's a good mother, being upset because she sees other people who are doing a better job with her children than she could when she was in the throes of her depression. She's better now, right? So a lot of treatment has to include, in my professional opinion, should include therapy as well as the medication. If needed, the medication is needed. Again, sleep is there again. If as professionals or caregivers or helpers or family members, if we can somehow help both mom and dad get sleep, they're going to function better. And right now, I've been recently concerned about dad in the family, because the plan is that she's going to get sleep, so she sleeps through the night, and she's breastfeeding, but at night, dad bottle feeds. So dad's up, and then he's up in the day working. So my concern about him is how he sleeps. I always check in with him. How did you sleep last night? How much sleep did you get? Right? And then there are other treatment modalities as well. I think Dr. Yagman will talk some more about that. So ways to help the mother in your life. If it's professional, you want to connect them with resources. But if you're listening, and I think that's a very important piece of helping, is listening, and listening non-judgmentally. And I think that's part of actually mental health first aid, and I have some copies of mental health first aid outside, and they're free courses you can take by checking on mentalhealthfirstaid.org. But listening non-judgmentally, listening to the worries that mom has, so she'll share with you what her thoughts are and not feel like she's being criticized or judged. There's the rest again. Acknowledge the things they do well. Jay sent me a text today that she did a few things yesterday that were hard for her, but she did them and she feels good. And I think that, and I said I was proud of her, and she thought that she really appreciated my saying that. And so, acknowledging, even if it's a small thing, when she had her first pregnancy of postpartum, where she was severely depressed, she wasn't able to get up and take a shower. When she got up and took a shower, it was a big deal, and I praised her and acknowledged how hard that was for her, and then it was great she did it. So those are the kinds of things that they need. And then letting her know she's not alone. We didn't leave her alone. Now we can, because she's better. And you offer hope and reassurance. Jay needed a lot of reassurance about how she was doing, what she was doing. And she needs so much less now. She appreciates it, but she's more confident in her ability to care for her kids. And she has 3 now. When I came in, she had a 2-year-old and then a 3-month-old, and she since has now an 8-month-old. And another thing is, and this is one that a lot of people can do, cook, do dishes, laundry, clean, childcare. I did those all. I wasn't alone in my helping. Her mother-in-law and I took we split up the week and took 2.5 days each, and were there when the husband went to work, and helped with all of these things. And I still help with childcare because I'm so bonded with the two little ones, the two older ones. So, but one of the things, this is a suggestion, I don't know if anybody knows about meal trains, but meal trains are great. They have such a strong faith community that they just sent out a text to one person in the faith community, and there were people who didn't even know them that were making meals and bringing them to them. So that way Dad didn't have to worry about cooking at night when he got home from work, that there was already a meal for them. That lasted for quite some time. The first time was difficult. This time, she's better because she has intervention earlier. And but they still did meal trains again after she delivered the third child. So those are some ideas. And even if a person can go and spend 2 hours to provide respite for Dad or another caregiver or for Mom, that is a huge help. So recommended things not to do, okay? Telling somebody to snap out of it, criticizing or judging them, comparing them to other moms, have another drink of wine, right? Those are not helpful or healthy things to be doing. And I think that something Carrie wrote, which was very compelling, that I want to repeat. She says, "Comparison is the thief of joy, and no person is harder on themselves as a new mother." So that's not something that's helpful. And one of the things, too, although Jay was very strong in the faith community, people in the faith community would sometimes tell her that she didn't have enough faith, which was not helpful. She has a lot of faith. And so, not saying things that the mother might take so personally and negatively when this has been a strength of hers all her life, to tell her that she doesn't have enough. That was not helpful. So if you know the mother, to be thinking about what things for them are more helpful than not. And so, family and friends may notice first if someone is having mental health changes. And I think that's really important if you're working with families who are working with a mom who has a newborn, to help teach them what to look for, help teach them the signs and symptoms that I just mentioned, so that they can intervene and they can help, and at least be aware so they can let a health professional know that they're concerned. So resources for support. Postpartum Support International. I can't stress it enough. I've been on the website. There's information for professionals, information for individuals. There are all kinds of support groups. They have support groups, bipolar support, adoptive foster support, dad support, families touched by psychosis. There are many, many support groups and connections, and calling them or getting on the website and then filling out a form, somebody will contact you within 24 hours to help get you find other resources. And then there is the maternal mental health hotline, so there's the number for that as well. But again, this stuff is all on that website, so you don't have to write it down. And I will stress again in this next slide about mental health first aid and checking that website out as well. And again, the courses are free. So in emergency, if it's life-threatening, 911. If something's happening where a mom is not safe or a family member is not safe, then you need to call 911 because they'll get there sooner than a 988. 988 is a great number. I called it and just spoke to someone about resources and what they do. And they'll connect you with local resources. And I'm not sure if everybody is aware of the Mobile Crisis Unit in Bristol County. But the Mobile Crisis Unit is from Child and Family Services. There's information out in the lobby about it. If you call them, they will triage and they will send out a mobile unit within an hour. So if you're having trouble and you don't think it's a 911 call, call 988 and they'll guide you and direct you and get you the resources, and if needed, have the mobile crisis team come to you and come to the mom. And of course, there's the National Crisis Text line as well. Okay. So important takeaways that Carrie wanted you to leave here with. You cannot tell by looking. We must have these difficult conversations and ask direct questions in a non-judgmental and supportive manner. And one of the questions that we might need to ask very directly is, are you feeling suicidal? Are you having thoughts of harming the baby or your children? You're saying that is not going to make them be suicidal. You're saying that is not going to make them want to hurt their children. But you are getting to the nitty-gritty of where your concern might be, depending on what the thoughts are that mom is having. And postpartum depression does not lead to infanticide. And you saw that it was a very small percentage. But we still need to be concerned. And again, early intervention is key. Postpartum psychosis is a medical emergency that must be addressed immediately. Never leave mother alone. And that with help, you can and will get better. That's what you want to communicate. That's what we want to communicate to people in the community. My friend Jay is a great example of that. She continues to need support, but she's gotten better. And she's able to have some quality of life with her 3 children and her husband. So, but she did it with a lot of support. She did it with professional intervention. And she did it because of her great love as well for her family. And she just needed the support to be able to tap into that and use that as her strength and a protective factor. So, with that, we cannot prevent PMAD, but we can help and mitigate the symptoms and experience through education, support, and resources. The message of help is the source of hope. Thank you. And now, I would like to introduce our next speaker, Dr. Michael Yagman. We are so fortunate to have Dr. Yagman here today, because I'm going to read his bio, and it's a brief one. I'm honored to introduce Dr. Michael Yagman. Dr. Yagman recently retired from pediatric practice after 35 years and continues to teach, write, and do research as assistant professor of pediatrics at Harvard Medical School. Dr. Yagman received his medical degree from Yale University and holds a Master's of Science degree in maternal and child health from Harvard School of Public Health. In addition to his role on the board of the Franciscan Children's, he serves on the Leadership Council of the Center on Universal Education at the Brookings Institute. He is a trustee of Boston Basics and a chair of the advisory board, a past board chair of the Boston Children's Museum, immediate past chair of the Massachusetts American Academy of Pediatrics, that's the AAP, Child Mental Health Task Force, and past chair of the National American Academy of Pediatrics Committee on Psychosocial Aspects of Child and Family Health, where he has authored policy statements on father's role with children, perinatal depression, the power of play, trauma, toxic stress and resilience, and addressing early childhood behavioral problems. He served as a legislative appointee to the Massachusetts Advisory Board on Child Mental Health. Dr. Yagman has received the Outstanding Children's Museum Award on behalf of the Boston Children's Museum at the White House in 2013. He was awarded the Sims Mann Foundation National Whole Child Award in 2015 and the AAP Senior Child Health Advocacy Award in 2016 for his work on postpartum depression. The Richmond Coleman Award at the AAP in September of 2017 for outstanding contributions to the field of child development and behavior through advocacy, public service, scientific endeavors, and literature. In 2022, the Mass Medical Society named him Community Clinician of the Year in Middlesex County. He now serves on the Climate Resilience Committee of the town of Westport, Massachusetts, where I also am on the committee and have had the great opportunity to meet and get to know Dr. Yagman, where he provides advice on the health effects of climate change on children and adolescents. Please join me in welcoming Dr. Michael Yagman.
Hi there. Yeah, gotcha. Really a joy to really be increasingly part of the Westport community and to work with Donna and and people in the South Coast. Donna did such an amazing job of presenting a lot of the clinical issues that we deal with in postpartum mood disorder or perinatal mood disorders. I have a bunch of slides, but I'm also happy if people want to just have some discussion and some questions and answers. So I'll start with my slides, but feel free to interrupt at any point because I don't think that, it's a small group. We don't have to be terribly didactic about this. I do think it's important to couch this topic in the broader, really emergency that we're all facing of the mental health crisis, some of which started before the pandemic, but was certainly exacerbated by the pandemic. And multiple organizations have talked about the crisis, particularly for children and youth, but for our whole population, about the epidemic of mental health disorders and how we're going to create a more adequate workforce to address this. So that's a real challenge. And I think we're talking a little bit with the school superintendent about what we can do to support students in the schools here in Westport. But I think it's important to couch this notion about, and you'll see in some of my introductory slides, the way we can think about stress and its interaction between the biology of stress and its effect on the brain and the social factors. And I think our Surgeon General has really highlighted a point that we made in a recent report we wrote for the Academy of Pediatrics about buffering stress. And it really speaks to Donna's role as a guardian angel for Jay. The most protective factor for any kind of stressful situation is a positive, supportive, safe, stable, trusted relationship. And that's really what it's all about. And so our paper is all about relational health. And if you've been reading some of the things that Vivek Murthy has been talking about lately as our Surgeon General, he talks about the way the pandemic exacerbated the isolation and loneliness that people experienced. And that becomes a real major risk factor of mental health disorders. And so reaching out to people, as Donna has done so marvelously with Jay, providing that kind of support and relationships. And if you think about the postpartum period, where mothers come home after the delivery and they're pretty housebound and often quite isolated, well, it's no wonder that the mental health disorders really become accentuated. Just wanted to couch our discussion in those terms. Let me run through a bunch of slides, but feel free to interrupt if it makes sense with questions. So I wanted to couch this in some really important work that the CDC did many years ago, in which they looked at a series of adverse experiences in a retrospective study from adults in a California HMO, and identified 8 or 9 adverse experiences. And adults that had 3 or 4 of those experiences, when they followed them over time, they found that they were highly correlated. Just this, any notion that physical and mental health are not completely intertwined is kind of completely obliterated by this data. These adverse experiences are highly correlated with long-term costly health problems, diabetes, heart disease. I'll go through the details in a minute, but we're never going to bend the healthcare cost curve, which is bankrupting our GDP, unless we begin to view our healthcare system as comprehensive and as encompassing both physical and mental health. Toxic stress, which I'm going to define in a minute, is that a term that is familiar to anybody in the audience? Anybody? Okay, so I'll run through it quickly because I won't bore you. But in the absence of buffering interventions, leads to, and here's where the data now really intersects with biology, leads to changes in brain structure and function, epigenetic changes, and childhood and adult behavioral morbidity. The supporting responsive relationships, as I alluded to, strengthening core life skills, reducing sources of stress, improve both health and educational outcomes. And my other work, and my recent work now, is all about the power of play and encouraging play as a way of encouraging parents and children to engage, encouraging children to engage with other children, learning a whole host of skills. That's another lecture, but we're now very involved in developing playful learning installations all over the country and all over the world that enable parents and children to interact at places where you would think they'd be wasting their time: bus stops, laundromats, supermarkets, neighborhood playgrounds. Managing perinatal depression, engaging fathers, encouraging playful learning to build executive function skills, integrating behavioral health and primary care, and care coordination are all concrete examples that have the potential to improve outcomes if interventions can be individualized and embedded within the context of a trusted relationship. Again, back to the importance of relationships. And breakthroughs in 21st century science will require the transformation of healthcare to precision medicine. So the notion that universal algorithms can override individual characteristics is something that we need to kind of address. So these were some of the adverse experiences that the CDC study developed. And you can see that maternal depression was at the top of the list, other than poverty. But witnessing domestic violence, verbal abuse, physical abuse, relational traumatic stress, physical abuse, sexual abuse, I'll run through this pretty quickly. But they're the most basic cause of health risk behaviors: morbidity, disability, mortality, and healthcare costs. We can go through the litany of statistically significant relationships between adults that had 3 or 4 adverse experiences in their childhood, and it was a huge percentage. You'll see that data in a minute. But alcoholism, chronic obstructive pulmonary disease, fetal death, illicit drug abuse, ischemic heart disease, liver disease, sexually transmitted diseases, smoking, suicide, early initiation of smoking, heart disease, diabetes, liver disease. Here we go. You can see that the odds ratio for adult heart disease goes up, directly related to the number of adverse experiences people experienced in childhood in this Kaiser Permanente study in California many years ago. And it's been replicated totally. Now, these are just to give you the definition of toxic stress. So everybody experiences positive stress and learns to cope, and that's adaptive. Tolerable stress, serious temporary stress responses, but buffered by supportive relationships, as opposed to toxic stress, which is prolonged activation of the stress response systems in the brain that, in the absence of protective relationships, really can, and I say can, but not necessarily, produce long-term changes in the pituitary adrenal axis, changes the immune system, changes metabolic systems, and I won't bore you with some of the measures that we've been looking at in biomarkers of stress in young children. But you can see this in brain imaging in a host of. So again, social emotional suffering is the primary factor distinguishing. Let me move ahead because I want to get to its effect on development in the first 3 years. These are children with developmental delays, again showing its connection to ACEs. And you can see in this slide on the right that postpartum depression is one of the major sources of toxic stress in children ages 2 to 5. This is my slide about resilience because I don't only want to focus on deficits and negatives, but on positive, supportive, protective factors. And you can see that supporting responsive relationships, strengthening core life skills, particularly executive function skills, are critical towards enabling people to cope with stress and recover. The long-term effects of maternal depression in infancy, we have now data that stress hormones in adolescence are up when maternal depression in the perinatal period is untreated. So, clearly, the major impact not only on the mother, but on her interactions and relationships with her child can be hostile, intrusive, disengaged, and withdrawn. And when I was a fellow many years ago with Barry Brazelton, we did some work with a simulated perturbation where mother or father would come in and sit opposite the baby and play and have this beautiful interaction, and then we'd have them leave and come in and keep a still face. And you could see within 30 seconds the effect on the baby of slumping in the chair, of frowning, of making gestures to try to pull the mother back in. And of course, when she wouldn't respond, it became, and you can see that was 2 minutes. The mother would leave and come back, and there'd be immediate recovery when she began to interact with the baby. But you can see why that over a period of weeks and months would have such a devastating impact on the baby. So, statistics depending on the sample, I forget Donna's numbers. The numbers are all over the map, but they're high. 1 in 7 in some studies. Interesting. We focus a lot on gestational diabetes. Depression much more common in the perinatal period than gestational diabetes. The 2/3 begins before birth, as Donna pointed out. And it speaks to the importance of obstetricians and pediatricians communicating. One of the problems with our healthcare system is it's all siloed. But, if you're going to identify somebody who's depressed prenatally, you want to make sure the pediatrician knows about it so they can begin providing supports from the get-go and not have to reinvent the wheel. Now, I've been very interested, and we're actually in a bit of an advocacy thing about screening fathers, because in fact, fathers also experience perinatal depression, and it presents a little differently. Probably because of stereotypes, fathers are less likely to exhibit sadness and weepiness, but I think you can explain a lot of the postpartum substance abuse and domestic violence, undermining breastfeeding, irritability in fathers with postpartum depression. And we'll talk about screening in a minute. The existing screens work for both parents, but I think we're working on some screens that capture the the slightly different range and spectrum of paternal perinatal depression. And we're in the midst of advocating with the Academy of Pediatrics that pediatricians should screen not only mothers, but should begin to screen fathers at 4 and 6 months as well, postpartum. But we'll see. Adoptive parents, similar rates as birth parents, so it's not just biology here. And I think we'll talk about the, on the left, Donna talked about the effect on the mother, but the pregnancy, preeclampsia, maternal suicide, prematurity, low birth weight, cognitive delays, we can go on, but clearly it's talk about healthcare costs, increased ER visits, delays, inability to sustain breastfeeding, we can go on. But here's the real challenge. In spite of, I've been at this maybe 10 or 12 years and been on the Postpartum Depression Commission of the state, written repeatedly and lectured everywhere to try to get pediatricians to screen, but we're doing better on screening, but we're still probably approaching 50 to 60%. But the follow-up and the treatment is, in outer space. It's just not happening the way it should. And so it's underdiagnosed, but more seriously undertreated, even when it is diagnosed. And I want to point out, as I think Donna mentioned, screens are not a diagnosis. Screens are a red flag to get people help and support and to kind of create, do a more fuller diagnostic assessment and then figure out the appropriate treatment and support. Well, we talked about the spectrum from postpartum blues, which are, fairly ubiquitous, to depression to psychosis. The risk factors, I won't go through this again because Donna did such a beautiful job of isolating this. Yes. Come use the microphone so everybody can hear. Thank you. This one? Yeah, exactly. And your name?
My name's Carrie.
Carrie, yeah.
Hi. You mentioned that perinatal mood disorders within the first 6 months. I'm studying to take my LICSW right now, so I'm sort of really getting back into a lot of the academics of this, and I was learning that perinatal mood disorders are actually only diagnosable within pregnancy to the 6 weeks of the postpartum period, and that's as updated in the DSM-5. Is that correct information right now?
Don't get me started on the limitations of the DSM
so I was
diagnosis for billing. But no, so in fact, I think we clearly now have good data that postpartum depression can occur anytime, both during pregnancy and for the entire first year.
Right.
And in fact, our recent recommendation, and a recommendation supported by the U.S. Preventive Service Task Force, in spite of that Texas judge, suggests that we screen at least at 2, 4, and 6 months, and we've been pushing to screen at 9 and 12 months. In fact, there's a pending legislation in the Massachusetts House for that, but it's certainly 6 weeks is way too early to, in fact, I think most people don't really present with depression until long after 6 weeks.
Absolutely, and that's sort of when postpartum care ends for the mother too at 6 weeks. So
Right.
You're saying that screening is happening more in pediatric offices within the first 2 years?
Yeah, the absolute recommendation to pediatricians is to screen at well visits at 2, 4, and 6 months.
Mm-hmm.
And we'd like to expand that even beyond that, because we've seen instances where it can happen as late as a year.
Sure. So how do you think, what are the implications for a woman's treatment based on the limitations of the diagnosis at this point? Are there implications? Is this because of the diagnosis being so limited within that time, is that why we're seeing some of this lag in treatment? I mean, there's a lot of reasons, I'm sure.
Well, so number one, I think given our work in Massachusetts now, screening is paid for by all insurers, including Medicaid, right through the whole first year. treatment is a little more complicated. We do have that I can talk about in a minute, we have a pretty innovative consultation available to pediatricians called MCPAP for Moms. The Mass Child Psychiatry Access Project now has an ancillary group that a pediatrician can call. We'll talk about, management in a minute, but just to jumpstart this conversation, one can call them and literally within a half hour get advice about resources for treating moms who screen positive. I think that obviously a lot depends on commercial insurance. I think Medicaid will certainly will pay. We had this battle about paying for screening, which we won, but it was a long fight. But they now, because typically the baby is the subscriber, and we got them to acknowledge that you could screen the mother on behalf of the baby and be paid for under the baby's Medicaid number. But I think the issue of treatment depends on the mother's insurance.
Right, the treatment and the diagnosis. So if she's within her first, say, 2 years of postpartum and she doesn't have the correct diagnosis, I'm just curious, and I don't think you have the answer, or we're just sort of having the conversation about how a misdiagnosis also impacts her treatment. Will it be a big difference in treatment if she's diagnosed with major depressive disorder as opposed to a PMAD? I'm curious how that might impact her.
It shouldn't, and I think that, it becomes a very individual thing, and a good clinician will fight and advocate to get that mother care. And I think the reason why people are not getting treated, and even worse, not getting followed up, probably does not have as much to do with insurance coverage as it has to do with a broken healthcare system that's siloed. And, I can just tell you, I would not take no for an answer when I had somebody I was concerned about. I would find them treatment, and I would follow up and make sure they got better. I can tell you a wonderful story about, I used to think, I'm a good clinician, I don't need to use these screening instruments. Well, about 8 years ago, I had a woman come to the office who I'd seen prenatally at her 2-month visit with, she was an investment banker, an Asian woman, an investment banker, dressed to the nines. And my office staff, who are very perceptive, said, she's in great shape. How many 2-month-olds come to the office looking like that with 2-month-old babies? And I looked at her Edinburgh, which we'll talk about in a minute, and she was suicidal. And I fortunately had a co-located social worker, walked her across the hall. We had to call 3 ERs till we found one that was able to accommodate her. We made sure her husband accompanied her. We called the ER, make sure she got there. She was admitted to McLean and treated without medication. Did beautifully after a relatively brief hospitalization with mostly just psychotherapy. I continued to see her. She fully recovered and got the most, I still remember the birthday card in her son's first birthday said, you saved her lives. Because she was literally thinking of harming her baby and committing suicide. But I think that the gap is not so much related to billing and diagnosis, and I think it's becoming less of a problem as the world acknowledges the prevalence of mental health disorders and the need for treatment.
Right.
The problem is the workforce, finding people that feel like they really know how to treat perinatal depression. And particularly when I've referred fathers, they act like, what are you, crazy?
Right.
But just to give you an example of why this is now, much more, today, I don't know how many people saw the New York Times today, but the Science Times has a big article about postpartum depression in today's paper. So there it is.
Mm-hmm.
So,
Thank you.
really good point, but, just,
Yeah,
don't worry about any kind of 6-week cutoffs.
Right.
It's the whole first
I
year.
know,
And
it's just talking about it too. Postpartum International really tried to encourage the 6-month cutoff at least. So I think even for a woman to understand if she's getting that information that she should be good to go after 6 weeks. It's like that's just what we need to be talking about in our fields. Is that this book is not everything.
yeah, right, exactly.
Thank you.
No, and DSM codes are often hopelessly out of date, so. Okay, so we talked a bit about bipolar disorder and its risk for psychosis. It's a major risk. And one of the things you need to be careful about is if people are too quick. I'm not a big fan of medication, although, it has a place. But one of the things you need to be careful about is when people are placed on SSRIs like Prozac or Zoloft, without being carefully followed, that can precipitate in somebody who has the underlying risk of a bipolar disorder, that can precipitate it. So that's why there's a black box warning on those medications. So, and you can see the slippery slope during the postpartum period. Let's zip ahead and talk about pediatricians and the uphill battle to get people to screen, because we're still probably 50 to 60%. But the U.S. Preventive Service Task Force now mandates payment for screening under the Affordable Care Act. This is a major breakthrough because they can be very hard-nosed about the evidence base before they'll make a recommendation like this. But combining depression screening with adequate support systems in place improve clinical outcomes for pregnant and postpartum women, and the prime recommended treatment is CBT, cognitive behavioral therapy. So we're encouraging screening mothers and fathers at within the first month, at 2, 4, and 6-month visits, using typically the Edinburgh, which is the preferred screening instrument, validated in pregnancy and postpartum with pretty good sensitivity and specificity, cross-cultural validity, available in multiple languages. The critical thing is the 10th question, which asks about self-harm, which some of the other instruments that people think they can get away with doesn't ask about self-harm. There's just so much data about the validity and usefulness of the Edinburgh. And people I never had anybody in my office quibble about it. And I'll just say that you can be fooled and think, as I was with that Asian woman, that somebody's not depressed, and yet they'll acknowledge it on the Edinburgh, and you'll be surprised, but glad that you screened. Self-report, possible depression cutoff of 10, always look at item 10. Again, it's a screen, not a diagnostic instrument. The barriers to treatment, many of which Donna talked about, stigma, limited access, discomfort of providers. What am I going to do if somebody screens positive? Well, there are very specific things you can do, and it doesn't have to, destroy your time schedule. You can call the mother's primary care physician. You can call the obstetrician. You can call McPAP for moms. You can discuss with her. Sometimes people are already in treatment, and you can say, well, have you discussed this with your therapist? And would you like me to call your therapist? We can talk about all the problems. And the real problem with the workforce is, as many of you know, finding somebody who has availability, and especially somebody who takes insurance, is really an uphill battle. CBT, 1-year follow-up, demonstrated 35% remission of symptoms compared with usual care. New medications recently approved. The Times discussed this today. For people who are severely depressed now, there is a 3-day IV infusion requiring hospitalization of a drug called brexanolone. And there's an oral medication that's in the congener of that drug that's in the final stages of FDA approval called supranolone, I think was the name. But data about effective treatment. And I think here the message that I have is that it's kind of unrealistic to think about the standard modality of treatment, which is to ask the mother to come to somebody's office or alone. What does she do about her baby? And plus, the focus of treatment is not just the mother, but it's her interaction with her baby, which can often be colicky and can exacerbate the symptoms. So I think we need to create a workforce that's comfortable with dyadic treatment, treating mother-baby pairs or father-baby pairs. So when they, in the STAR-D trial, when they treated mother-child pairs across 7 regional centers, treating the dyad showed promise of even better child outcomes. And I think here is the toddler parent therapy improves cognitive development. So you can see the treated mothers had babies that were doing as well as non-depressed mothers in a randomized trial using the Bailey, which is not the best outcome measure, but it's has some psychometric validity. So we talked about suicide, previous history, high lethality of previous attempts, recent attempt, current plan, current attempt. And again, making sure that even if somebody is not currently suicidal, to make sure that availability of any kind of dangerous weapons, guns, knives, things like that, or medications are unavailable, so that safety in the home is paramount. Harm to the baby, again, Donna really did a beautiful job of discussing this, and so that's probably a good place to stop and take questions. Discussion. Other people have experience. Go ahead. Come on up to the mic.
So actually I have a question. So I work in early intervention. I find that lots of families are worried about disclosing some of these things because they think that immediately DCF is going to be involved. They're going to try to take away their children. So does seeking help through these means often initiate that? Like, how does that go with DCF?
So, that's something that we all grapple with, the issue about confidentiality. And I think one of the issues that came up early on in some of this that pediatricians were screening, was it going to be in the medical record? Could it be used against the mother in a divorce proceeding? And so I'm very careful with the language I use in the medical record. I talk about stress rather than using diagnostic labels. And I think that's a little bit protective. I talk about the universality of the stressful period of the perinatal period, and try to, avoid the stigma. I think that it's still and there are real cultural differences. So in certain cultures, any kind of mental health concerns are taboo. And so I think you have to avoid some of the nomenclature that puts this in the mental health frame, and talk about stress and needing support and needing diminishing isolation. I wish that we had a system, something we've advocated for a long time. I wish that every birth hospital would, maybe we can do this in Westport. What a wonderful opportunity for banks or community businesses to say, once a week, for all new mothers who come home with their babies, we're going to have a support group in our bank with, some kind of facilitator, just to connect people and diminish the isolation. People really enjoy some of the prenatal classes because of the people they meet, but then they go home and they're isolated for the next 6 weeks, and that is a huge risk factor. So anyway, that's something that we could try to advocate for.
Right. Yes. Okay.
I think you were asking if it triggered DCF, and it does not necessarily trigger that. In the case with my friend Jay, she had adequate supports in place that did not require any intervention from outside an agency. If you have somebody who's alone and isolated and you're concerned about their safety, then that, or the safety of the child, then that may cause a clinician to make that connection, but you really have to look at individual cases. If the support is there, and also you're assessing, is the person really at imminent risk? As I said, Jay knew that her thoughts were something she did not feel comfortable with. It was uncomfortable. She was not going to do anything. We were concerned enough about her, we didn't want to leave her alone because we didn't think she could care for the children because she wasn't able to care for herself. But that was not going to trigger that contact. I think as a clinician, you have to make that determination. What's more important? The safety of the child is very important. The safety of mom is very important. But it doesn't necessarily trigger that kind of response. And I agree. Moms may not want to talk because they're afraid that will happen. And it depends on the social circumstances of the mom too and her past experience with that. Are you working in a population where DCF is involved regularly?
Yes.
Yeah, okay.
Yeah. So at the early intervention, we're in Bedford, so we have lots of DCF referrals straight out of the hospital even. But I know a lot of parents just aren't comfortable. I feel like they have, especially when they have a guard up when they've had DCF in the past about talking about things. So those families, sometimes I'm especially worried about. But
Yeah, I think, as with many things, it comes down to the fact that if you can develop a trusted relationship with the family and they know you're on their side and you're going to protect them, and you'll use language that's protective, but which early intervention program are you with?
the Kennedy Donovan.
Yeah,
Center.
I think I've actually sent some kids to you over the years.
Great.
So, great.
Yeah.
Yeah, you
And
guys-
I actually did have one other
Yeah, go ahead.
question too, because I find that working with this stuff, it can be hard to keep a professional boundary at times because you are becoming so enmeshed in the family. Do you feel like it's important to kind of keep that relationship, the professional boundary, or do you feel like, because I find that it's more effective when I don't as much, because they actually find me to be more of a friend that they can actually talk to, and I don't know.
Well, I mean, so the boundary question is also complicated. I think there are limits to boundaries, but I think that, for example, home visits are a really important way to really understand the specifics of a family, and I
Right,
often think
yeah.
there's some benefits to that. So
we have an opposite situation with my friend Jay. I didn't go in as a healthcare professional. I didn't have to maintain those boundaries. However, as a friend, I had to develop boundaries so that I wouldn't become her therapist. And that's what started to happen. And then I had to learn how to say, you need to talk to your therapist about this. I want you to call your doctor and tell your doctor you're feeling this right now. So while I was there, she would pick up the phone and call the doctor, right? So when you're certainly, you want to connect and engage with your clients, but you still have to have professional boundaries. And you can still connect and engage. You can be warm, you can be caring, you can share some information that might be personal, but always remember your professional position with the client. And always, what I do with clients, as well as I, get close to some clients, as your therapist, as your nurse, your safety is my priority. And so I have to say this or do this or tell this person because your safety is my priority and concern. And I even, when I'm talking about these things, change the tone of my voice so that they're hearing the warmth from me that I care about them. But we always have to remember in a professional setting that we have to maintain a professional boundary but still be kind and caring and compassionate and loving towards the kids that we're taking care of or the families that we're involved with. And if it becomes a problem, That's where supervision is very important. And if you have a supervisor, that's when you sit down with your supervisor and say, I think I'm getting a little, my boundaries are getting a little blurred, I need some help.
Thank you so much for your input.
Yeah, these can be very complicated. I mean, I'm thinking about, you get some DCF referrals, and you're developing an alliance with the mother, and then all of a sudden, there's a question about an injury to the child. And you have a professional obligation to report
Yeah,
that,
of
but you
course.
know that's gonna really interfere with your relationship with that mother. So it's a very slippery slope, but, you know, you are a professional.
Right.
Yeah.
No, of course. Thank you so much.
Good. Other questions? Well, good. Donna, would you wrap us up?
I first want to thank Dr. Yagman for being here. We're very blessed to have him living with us here in Westport and providing his expertise. And so I also want to stress with everyone that if how many of you here are working in health, mental health care, or social services? Okay. We have a tough job. And one of the tough things is when you get attached, and you're in this profession because you're caring people. You have hearts, right? You have to take care of you too. And you have to watch how you take care of yourself so that you can take care of others. I've been a nurse for, it's actually 43 years. And one of the things I learned very early on is I am the best nurse I can be when I take care of me. And so sometimes that's boundaries, right? Sometimes that's boundaries. In part of mental health first aid, I also did a presentation last Monday on that, focused on youth, and that's also on the Westport Community Access TV site. In mental health first aid, they talk about what you learn about is that you have to take care of yourself. And part of taking care of yourself is being aware of when you need to take a break and a step back. And so hopefully you have people that you're working with that you can go to, supports. I mean, we talk about relationships and support. We need them too. Dr. Yagman needs them. I need them. We all need them. We're not invincible. We have our areas of vulnerability. So in part of Mental Health Awareness Month is, part of it is being aware of your mental health and what you need so you can be there for others and be there for these tough situations that we're talking about if we're dealing with moms with infants and concern about the safety of both. So, you know, if anything, that's why in my beginning I said, and ourselves, and being aware of stuff, challenges that we ourselves are having, that has to be part of the equation in caring for any patient or any person who needs your help. So I encourage you to please take care of yourselves. And I thank you so very much for being here this evening. And I hope you share with other people to maybe watch it on the YouTube station if you thought it was helpful. So thank you again.